Um, so welcome everyone to the National Fellow Online Lecture Series. Today we will be having a lecture on rheumatology issues in MSK. And my name's Heather Saffel. I was the fellow representative when the subcommittee was first started, and currently am on faculty in South Bend at the Notre Dame Fellowship. So today I will be welcoming Dr. Hamish Kerr. He is board certified in internal medicine and pediatrics, completing training in overseas in Europe and in America here. And so he is currently the vice chair of academic development in the Department of Pediatrics. He's the program director in primary care sports medicine at Albany. He's also the head team physician of Siena College, as well as team physician, and is the chair of the medical and research risk committee with USA Rugby. He's also a concussion consultant and the senior medical educator and trainer of World Rugby. So without further ado, I will let Dr. Kerr take it away on rheumatology issues and musculoskeletal conditions. Go ahead and get started.
All right, thank you, Dr. Saffel. Heather has actually been very, very involved in this committee and has given all the fellows on the call perspective from her fellowship, and it's been very useful for us to kind of have a more learner-centered approach to what we've put on this year. Just a few reminders of what we're trying to accomplish here. It's not really trying to take over from the individual program education, but just to provide all our fellows some access to AMSSM members around the country, some of whom are guests. Myself, I'm going to exclude from that, as you'll see in subsequent slides, but it's meant to help you with your CAQ exam prep, but it's also meant to provide you some real-world sports medicine experience that you may not get from your individual programs. My background, as Heather mentioned, is on the online education subcommittee too, as well as these other physicians that you see. Heather's going to be changed from a fellow representative to being faculty on the committee since she's now in her first year of practice. And we've all kind of been contributing to this experience this year, and it's been really useful and enjoyable to be involved with. My background, I'm just going to highlight a couple of things here. I do work with a medical school, so we have done a tremendous amount of online learning this year for our medical students, and I think the fellows have benefited from that. I see a few of the faculty from our New England collaboration on the call today, and Dr. Mancini in particular at UMass has been instrumental in us delivering online education to our New England fellows on Fridays. And we wanted to bring some of that experience to the national platform because what we've been doing on Fridays is a little bit more interactive than what has necessarily been the norm for the online national lecture series on Wednesdays. So today is going to be more interactive, and you guys are going to get a chance to answer questions and use the poll function within Zoom. So Andy Meyer, shout out to you for setting that up. Thank you, Andy. He's going to be in the background making sure that the poll is up and running when we get to the questions. I am focused today on that poll function part, but there are opportunity for you guys to answer or ask questions through the chat function. So even if if something's not covered to the extent that you want, please feel free to use the chat function, and Heather and I will try and get to those towards the end of the presentation, and do try and complete the evaluation at the end as well. So we chose to delve into some rheumatology today. We're going to use a case-based approach to go through some cases. That's something that I do quite a lot of. I do a lot of rheumatology teaching with the second year medical student class. We've actually just finished our 2-week musculoskeletal theme for the medical students, and we cover a lot of rheumatology. And it's, you know, it's always interesting going back to read the science and clinical presentations of rheumatology, because most of those are quite complicated and they can kind of rear their head in many different ways. I am certainly not a rheumatologist, and I don't claim to be, but I did do internal medicine pediatrics training in my residency training, and I spent some time rotating with rheumatology, and in fellowship I actually got to do a block of rheumatology too with the pediatric rheumatology division at Children's Hospital in Boston, and I've tried to learn from that, and you'll see some of my cases reflecting that today. So without further ado, this is a list of cases we're going to try and get through. We've got 8 of them, and each has a little different perspective on the rheumatology manifestations in sports medicine. Some of the cases are longer, some of them are shorter. So without spending too much time looking at those, we'll get on with the first case. So for everyone, this is a 55-year-old male golfer who comes in with a right shoulder that's painful, swollen, and has some redness and warmth to it. Doesn't remember any trauma, and gets an X-ray, which we can see in our screen here. And I probably can use the mouse pointer, but maybe I'll go to a laser pointer. Let's see. Hopefully you can all see that. So the X-ray really shows some calcium deposition here over the AC joint, and there also appears to be a kind of rim around the femoral head there. So that could be considered consistent with chondrocalcinosis. And so the joint is aspirated and yields some crystals. First question is, what these crystals should demonstrate what characteristics? And I'm just going to read through those characteristics in case there's people on the call who can't see the screen. The first characteristic is that they consist of calcium pyrophosphate. The second is that they exhibit negative birefringence. The third is that they're needle-shaped. And the fourth is that they consist of monosodium urate. So hopefully you can use the poll function now to submit your answer. And we will give that some time. I'm going to defer to Andy and Heather to decide how long is necessary, because I don't appear to have access to the poll. Let's see what happens if I submit. So usually we'll give this a minute or so for everyone to submit a response. Very good. Okay, and we now have a response. We can see that most people, 76%, felt that this was consistent with calcium pyrophosphate, and there's a smattering of people that chose the other answers. So I'm going to close that and move on to the next slide. And that was correct. So the calcium pyrophosphate crystals was the correct answer. And we're going to go through the other answers just to look at what why those were wrong. Picture here is of a opportune moment in history. You can see there Sandy Lyle, the first Briton to get the green jacket by winning the US Open. So that's what you get when you win the Masters. Sorry, it was the US Masters, not the Open. And if you want more information about that, there's a link to a website there. It was something that I remember growing up being a very famous moment for a Scotsman. But back to the crystals, those are crystals of calcium pyrophosphate, and they are typically rhomboid or rod-shaped with blunt ends. They are not needle-shaped. Monosodium urate crystals are the ones that are more needle-shaped, and those have gout crystals have negative birefringements on polarizing light microscopy. The chondrocalcinosis crystals have positive birefringence, and that is the difference between those two. That's like a classic board question. You should be able to get that right fairly easily now that you've had a reminder. All right, we're going to keep moving with our case. This is a 59-year-old female tennis player, and she is presenting with an acute attack of pain in her, I forget, is it her ankle? And it's very painful and swollen for the first 8 or 9 hours of symptom onset. You do the same thing. You have a aspirate of the joint and see that there are crystals with negative birefringence this time. There's also an ultrasound conducted, and this has that same double contour sign we can see here around the head. I think this is the first metatarsal actually, and the first MTP joint. And there's also ultrasound finding of clumps of sugar, which we'll also see on a subsequent slide. So those are the findings. The question we are going to ask you is, which of the following would not be considered first-line treatment for this condition, for this attack? So have a look through those choices and submit your answers. The first treatment is colchicine, Colchris. Second is ACTH. The third is NSAIDs, non-steroidal anti-inflammatory medications. The fourth is allopurinol. The fifth is corticosteroids. So 5 choices. Which of those choices would not be considered first line in treatment of this attack? And the answer is, from you guys, allopurinol was the top answer, ACTH was the second top, and no one thought NSAIDs or colchicine. So that's good, because those definitely are indicated. Shout out on this slide to Andy Murray's mum. I couldn't highlight Andy Murray because he didn't fit the demographic, but his mum did. And she's a tremendous tennis player too, and an all-round good tennis parent, according to this article. So I just thought we'd like to share some positivity about the tennis world and parents who behave themselves on the sidelines. The correct answer in this case was indeed allopurinol. That is not the correct answer, because that is a controlling medication to prevent the uric acid levels elevating, and you should not use that in an acute setting because it can just worsen the acute attack. All the other answers were correct, although certainly colchicine and NSAIDs are more typical. I have not seen ACTH used very often. Corticosteroids I do see used from time to time. The worst symptoms of gout typically do occur in that first 8 to 12 hours. It's usually just one joint that's affected. We've reiterated the fact that the crystals are negative birefringent. And other things to consider: if you get an x-ray of the joint, you will often see erosions. You can see it in the highlighted slide here that, you know, podagra, the first MTP joint being affected, is common. An x-ray will typically show that the joint space is maintained. There's not narrowing of the joint space that you would see in arthritis. Typically no osteopenia, normal bone mineralization, but you'll see erosions with overhanging edges, like you see here in the bone around the joint. Ultrasound, as we said, will typically show wet clumps of sugar, which is kind of well depicted here, and may also identify bony erosions. And again, the allopurinol is contraindicated in the acute treatment of gout, but it's for long-term control. Okay, so this is a bit of a longer case this time. This is our third case, and this is one that I saw in fellowship. It was a 17-year-old football player who came in with hip pain, and he had had his anterior cruciate ligament repaired, reconstructed 6 months prior to his presentation, and he'd also had an established diagnosis of systemic lupus erythematosus, SLE. So we had delayed his surgery to get his SLE under control, and that had been diagnosed a year before his ACL surgery. He had been kind of well controlled with oral corticosteroids for about 8 months and continued on a low dose of prednisone. So around the time of the surgery, our concerns were more about just making sure that he got the right stress dose for corticosteroids during his surgery, because as we know, people on prednisone have their cortisol axis is inhibited, and they do need extrinsic stress dose steroids around things like illness or a surgery. He also had a pretty extensive thrombophilia workup, and during his immediate post-op period, he was on low molecular weight heparin, just to be sure that he didn't develop a clot. So these were the things that we were focused on during his surgery. He had very successful surgery, but we wanted to make sure he didn't end up getting a blood clot post-operatively, and we wanted to make sure he didn't have any consequence of being on stress dose steroids. He started having hip pain about 3 months post-op, and that was at the point where he was progressing from just doing lower extremity strengthening to actually running on the treadmill. And you know, the typical culprit, hip flexor tendonitis, maybe some IT band tightness was suspected. It's quite common for that to happen after an ACL reconstruction as you progress through your rehabilitation. But on post-op 6 months later, he still had really bad right hip pain, and that was a concern. Physical exam we had performed at that visit really did show a decreased range of motion, particularly with internal rotation. And you can see here when his hip was flexed to 90 degrees and his knee was in a flexed position, it was painful to rotate his right knee 15 degrees. Of course, in the picture, I've depicted a left hip being examined, but you get the point. He was also mildly tender over the greater trochanter. His hip flexor was a little painful with a straight leg raise against resistance, and he also had some pain with the flexion adduction internal rotation failure maneuver depicted in the picture here, and that was certainly particularly on the right side. We did consider his IT band as his Ober test was a little tight, but the principal pain seemed to be with internal rotation of the hip. His knee seemed fine. He had a full range of motion in the knee. There was no tenderness, no effusion. His Lachman had a firm endpoint. The surgical incisions were healed. Everything looked good in his knee. So, next question. We now have 6 choices. What is the diagnosis? First option is this indeed iliotibial band tightness and greater trochanteric bursitis? Does he have a hip flexor strain or tendonitis? Could it be something intra-articular? Is there a labral tear that had been missed? Does he have an occult femur fracture? Could he have a stress fracture that had become apparent now that he's running on a treadmill? Does he have some sort of arthropathy from his lupus? Or does he have avascular necrosis of his femoral head. So think about those options and submit your answers. Okay, so as you can see, the breakdown is more in favor of this being either hip arthropathy from lupus or avascular necrosis of the femoral heads, and less likely any of the other options. So let's close that out and see if you guys are right. First, we're going to look at some x-rays. This is the x-ray of showing the AP of the pelvis. You can see the right and left hip here. Does appear to be either gas overlying or some sort of lucency here. Maybe something in the right hip too. Not too obvious. No obvious fractures, and rest of the pelvis looks okay. There's a lateral really sort of showing the right hip in particular, and the left hip too, lateral. Not anything too striking, but this was indeed avascular necrosis of the femoral heads, and you were absolutely right. When we saw the femoral head with that suggestion of lucency, we suspected it was avascular necrosis, and we didn't stop there. We ended up obtaining an MRI, and this really does show those areas much better than the x-rays did. We can see that there's a lesion in the femoral head here on this view, and here and here. So unfortunately, both hips appear to be affected, and you can see with this view, you know, it's pretty significant how affected either femoral head is with the avascular necrosis. So the final diagnosis was bilateral avascular necrosis of the femoral heads, and the question is, why did he get that? This was thought to be predominantly a side effect from the chronic corticosteroid use he had had to get his disease under control. And, you know, it was a devastating second or third, really, diagnosis for this guy. He had been diagnosed with lupus, he had then torn his ACL, and then now he's got avascular necrosis in both his hips. So this was pretty tragic for this kid. He did see a hip specialist and was offered some treatments. The treatment options were a bit limited, but there was thought to be a vascularized fibular graft that might be indicated for the right hip, and the left hip may have benefited from an osteotomy rather than a total joint replacement. So learning points in this circumstance: first of all, don't assume that everything is the typical thing that you get in rehab. So very common to get hip flexor tendonitis and rehabilitating from a ACL. You do a lot of core work and a lot of hip work to regain strength in your legs, and it's quite common to get some hip tendonitis. If you get an x-ray, look out for those early signs of AVN. It can be pretty subtle, the lucencies that you see, and you're not going to necessarily see the end stage findings that you would expect with, you know, like a collapsed femoral head that we sometimes see. And then, you know, lupus itself is just, I said, the many evils of this diagnosis. If you look through all the bad things that can happen to you if you contract lupus, it is just manifold. There are every organ system in the body can be affected, and we were most concerned about his possibility of having a hypercoagulable state and getting a blood clot, and that didn't prove to be the case. The you know, he didn't end up down that rabbit hole, but there are other ways that lupus can come back to get you, and unfortunately the treatments for lupus aren't without their bad effects too. So something to bear in mind with your patients that you see with lupus. We've got a couple of patients that we follow in our clinic who have had musculoskeletal conditions, and getting their lupus under control is often just as important as addressing the specific musculoskeletal complaint. Okay, so we're going to move on to the next case. These are getting more and more difficult if you haven't noticed. And this is a 40-year-old carpenter, and he's coming in with increasing weakness in his legs. So the reason he knows his legs are weaker, that he had some difficulty climbing a ladder the other day. He can't stand on slanting roofs without having some difficulty. He feels like his arms are normal, except when he's working overhead. If he's doing any carpentry overhead, he can get some aching in his muscles. He, he also complains of fatigue, some aching in his wrists, some aching in his knees, and a dry cough. He was playing softball for his neighborhood softball team until 2 months ago. And right in the middle of the season, he basically decided he couldn't play anymore because he couldn't get around the bases. His legs were too weak and he was getting short of breath. And in his last game, he got a really severe sunburn, which you kind of see depicted, that old farmer's tan, suntan there, of the upper chest and neck, which was pretty bad in his last game. And he'd played all previous 10 summers without any of that happening, so it was a bit peculiar that he got this sunburn. 4 months ago, this is past medical history now, 4 months ago, he fell from some scaffolding and landed on his back in a pile of sand. That probably broke his fall a little bit, but he did have some back and neck stiffness after that fall. He'd gotten an x-ray and it seemed negative for fracture, so he was prescribed some muscle relaxants and kept out of work a couple of days, but he was back to normal within 2 weeks. He's had some peptic ulcer disease previously, treated with antacids, so probably shouldn't be taking ibuprofen. He had a distant history of fracture in his pelvis and a laceration in his thigh 5 years ago. And the reason for bringing those up is the injuries healed just fine. He recovered from those without any healing issues, without any protracted recovery. Social history, his softball training, that consisted of drinking 6 beers each weekend and smoking a pack of cigarettes every day. So pretty intensive stuff there. Family history, he has some family history, some emphysema in his dad, diabetes in his mum, and colon cancer and an uncle. But no family history of muscle weakness he's aware of. He's got 2 siblings that are alive and well, 3 kids, and a wife, all at home with him. Everyone's healthy. So getting to physical exam, he's a pretty muscular guy, appears his stated age, he's in his 40s, his vital signs were normal. He's got a rash though, and it's present over his eyelids, as you see depicted here in the bottom picture, and his cheeks to a lesser extent, his neck and chest as we'd seen in the original. And then over his hands, he's got the dorsal aspect of his PIPs and his MCPs affected with this kind of scaly red patchy rash you can see there. And his nails are affected too. They've got some erythema. You can see around the nail bed, periungual erythema. His ENT exam is fine. His neck's got a full range of motion. His thyroid's not enlarged. His chest does have some crackles on inspiration. You remember this guy is a smoker. And his rest of his exam, including his genital and rectal exam, was normal. Musculoskeletal exam's interesting here. He seemed to have a full range of motion of his joints without any swelling or tenderness particularly. So his lumbar spine seemed fine. Straight leg raise was negative. But trying to get him to go from a seated to a standing position, he really couldn't do that without leaning forward over his knees and using his arms to initiate the motion. So something abnormal in that. When he was trying to hold his arms up abducted, he really couldn't do that, even just with modest pressure from the examiner. So his grip strength, his bicep strength seemed normal, but once you got to his shoulders, he really wasn't able to resist abduction. He was able to stand on his heels and his toes without difficulty, but performing neck flexion, he had slightly diminished strength compared to what you would expect. No muscle tenderness, reflexes were fine, cranial nerves were intact, vibratory and pinprick sensation seemed to be normal, and he had a downgoing Babinski in his ankles. Did some blood work. Thyroid was normal. CBC, CMP, urinalysis were normal. You had a chest x-ray, and we can see that there's some increased interstitial markings. So nothing specific, but something going on in his chest. And he had a positive ANA. It was positive to the extent of a titer of 1 to 320 and a speckled pattern. His DNA, double-stranded DNA antibody was negative. Smooth muscle antigen, RNP were negative. SED rate was 40. So trying to paint a picture here, what do you think of these tests would be the most useful in confirming the diagnosis? First option is creatine kinase, serum creatine kinase. Second is serum aldolase. Third is EMG nerve conduction study. Fourth, serum protein electrophoresis, SPEP. MRI of his lumbar spine, muscle biopsy, bronchoscopy. 7 choices. Roll the dice. Actually, you can't roll the dice because that would be 6 choices. My bad. All right, so we can see what the consensus was. Actually, a smattering of most things. No one wanted a lumbar spine MRI. That's probably the first for that eventuality, but everyone, the majority were looking for muscle biopsy. There was someone looking for bronchoscopy. There could be a possibility there. SPEP, we got a few choices. Aldolase and CK, a few people thought, and no one really looking for an EMG nerve conduction study here. So let's see what else we've got about this case. Correct answer is muscle biopsy, but there are other things that can be useful. The serum CK and aldolase were 10 times normal, so that actually could have been useful to get to. His EMG wasn't specific, but did show a reduced amplitude and duration of the action potentials in the motor unit, some membrane irritability, some bizarre high-frequency discharges. The nerve conduction velocity was not slowed. That looked normal. So we did end up having a muscle biopsy, and that showed some increased variation in fiber size, some atrophy in the perifascicular areas, some degeneration, regeneration, fiber necrosis, interstitial mononuclear cell infiltrate. And then if you're getting into the real nitty-gritty, no evidence of fibrosis or inclusion bodies was seen. His SPEP and his MRI of the lumbar spine were normal. So it looks like the muscle biopsy was necessary, but that would have been probably preceded by the EMG nerve conduction study, CK aldolase in this case. What is your final diagnosis? We now have 8 choices. First choice is lung cancer. Second choice is a spinal cord injury. Third choice is systemic lupus erythematosus. Fourth choice, polymyalgia rheumatica. Fifth choice, dermatomyositis. Sixth choice, everyone's favorite, fibromyalgia. Seventh choice, either, we're giving you two here for the price of one, hypo or hyperthyroidism. Either direction, the thyroid is guilty. And then finally, muscular dystrophy as a final choice. And there we have it. So the majority thinking dermatomyositis, a few people thinking muscular dystrophy, and then one or two concerned it could be lupus. And the correct answer is dermatomyositis, and the biopsy findings are specific to dermatomyositis. And this is, you know, an illustrative case, just kind of combining the fact that the guy had objectively determined muscle weakness plus some skin findings. You know, the rash is kind of classic for dermatomyositis, Gottron's papules, and the eyelids being involved, the nail bed findings, all classic for dermatomyositis, which, you know, by its name combines muscular pathology with skin pathology. Okay, next case, we're now going to get into the realm of a 66-year-old ex-professional soccer player who comes in because his knee is kind of messed up. He's had too many injuries over his career, and he now needs a left knee replacement. However, he's also had rheumatoid arthritis for the last 25 years and has been battling that. It's been relatively well controlled, but his progressive left knee pain really limiting him. He can't hike anymore. He's got hard time with stairs and so forth. He is able to climb the stairs without any, you know, chest pain or shortness of breath. He's on methotrexate and folic acid for his rheumatoid arthritis, and he's basically coming to see us for a pre-op prior to his knee replacement surgery. You can see his vital signs look fine. His blood pressure's fine, heart rate, respiratory rate. He's got a good BMI. He's got ulnar deviation of his wrists and some swan neck deformities in his third digit, his fourth digit, all consistent with rheumatoid arthritis. And he's got pain and crepitus with range of motion in his left knee. Not warm, not red, not swollen particularly, but crepitus and pain notable. We did some LFTs, they looked fine, probably because of the methotrexate. His EKG and his chest x-ray are normal. What is the next best step in management here? Number one, do we need cervical spine radiography? Number two, do we need an exercise cardiac stress test? Number three, do we need pre-op spirometry? Or number four, do we need coag studies? Okay, so the poll answers are that most people want to get cervical spine radiography, but there's a smattering of people that want all the other tests, and that is interesting. When I was looking through this case, I decided to put it in the context of my favorite ex-professional soccer player from Scotland, and thought about what if he had had 25 years of rheumatoid arthritis and was getting a knee replacement. What would I want to do to make sure we did the best for him? And here he is, Kenny Dalglish. He's actually 70, but 66, close enough. Dalglish, the legend, the player, the manager, what would he need? I don't think he's got rheumatoid arthritis. I just made that up. But the thing that this person in this case would need is cervical spine radiography. And if we're getting cervical spine radiography, what are we looking for? And of course, the answer is atlantoaxial instability, which can happen in rheumatoid arthritis. You can get subluxation at the atlantoaxial joint, just as you can in Down syndrome, which we just reviewed recently in our New England lecture series. So x-rays are important pre-op because there may be some instability in the cervical spine, and that could lead to paraplegia if the neck is extended when you intubate someone in an anesthesia pre-op. So it's important that someone that's had rheumatoid arthritis for 25 years and could have some degeneration at the atlantoaxial joints, they really do need a flexion extension cervical spine x-ray to evaluate for that. This was a recent review article I noted on the subject from Gillick et al. In 2015. If you're interested in reading more about that, they actually go into some detail on how to interpret the flexion extension views and what you should do preoperatively for your rheumatoid arthritis patients that may be getting any type of surgery involving general anesthesia. Okay, good. So we're going to move on. More soccer players. This is a 30-year-old, and he's coming in because he's got some pain in his back. None of us can read that top slide very well because of the Zoom options. I apologize, but basically no radiation into his legs. He's just got pain in his back. It's worse in the morning and gets stiff and sore, but within a couple of hours it goes away, and it can come back at the end of the day and during the night, but he gets good relief from ibuprofen. He's healthy otherwise. He's performing and able to play professional soccer, and doesn't really have any other issues currently in his GI, GU, skin or joints. Exam, vital signs are fine. His eye exam's normal. Some pain with his range of motion, but just mild, and a little tender over the buttock area. No joint swelling, no tenderness in his extremities, no rashes. Wouldn't we all love to know what his SED rate and HLA-B27 are, but they're pending. And he's got normal x-rays, lumbar, spine and pelvis were included. So what's the most likely diagnosis here? First option is ankylosing spondylitis. Second option is lumbar disc degeneration. Third option is psoriatic arthritis. Fourth option is reactive arthritis. And everyone really thought, well, most people thought ankylosing spondylitis was the right answer. So the picture here is Darren Fletcher. Darren Fletcher was a professional soccer player and recently retired, and played for almost 10 years with inflammatory bowel disease. That's all in the public domain. I don't think he had ankylosing spondylitis, but a lot of my patients that I see with concern for spondyloarthropathy these days are not necessarily the classic ankylosing spondylitis that we see depicted here, but are people that have either psoriatic arthropathy or have inflammatory bowel disease related muscle or joint pain. And I think we have to remember that the spondyloarthropathies have a whole spectrum of disease beyond the classic that we all read about in medical school of ankylosing spondylitis, where you get better once you start moving around and exercising, and you're stiff and sore the first couple of hours in the morning. So young males with that history, that's a classic. But you can see this with psoriatic arthropathy, and you don't need to have skin disease to have psoriatic arthropathy. There's plenty of people out there that that have psoriasis, that their joint disease is the first manifestation of the disease. And I think that can also go for inflammatory bowel disease, although it's obviously more common that you've got some sort of history of bloody stools or colitis to some extent. Some people have the non-GI manifestations before they have the GI manifestations. So you've just got to keep that information in your back pocket and think outside the box once in a while for young patients like this. Let's see what else I said. Ankylosing spondylitis is the correct answer. And back pain, stiffness in the spine, worse with immobility and better with exercise is classic. Symptoms first thing in the morning, buttock pain. The change in the American College of Rheumatology's approach to this is that whereas when I was a resident, we were kind of poo-pooed from getting HLA-B27, now it's pretty established. Yeah, go ahead and get that. We can kind of hang our hats on that a little bit, although it might not be positive for everybody. It is helpful if it is positive. And the other thing that you should do is not stop with x-rays. You should probably go ahead and get an MRI because early findings will be apparent on MRI. You'll see some degree of sacroiliitis that you might not see on x-ray. So I've developed a much lower threshold for getting a pelvis MRI for patients that I suspect might have some sort of spondyloarthropathy. And particularly younger patients. Final two cases. Looks like we're doing okay for time, still got another 10 minutes, so should be able to get through both of these. 65-year-old woman here who has hand and wrist pain, worse with activity. Only 30 minutes or so of morning stiffness, past medical history of hypertension, diabetes, does not have psoriasis. No one in her family has psoriasis. She's on hydrochlorothiazide and metformin, and she has a mild effusion in her wrist on exam. It's got a slightly diminished range of motion, and there's some hypertrophy, bony hypertrophy at the DIPs and the PIPs, crepitus in her knees, rash, no rash or nail changes, labs, negative for rheumatoid factor, negative for CRP sed rate, and her uric acid level is normal. She has an x-ray as shown. What is the most likely diagnosis? We did perform an aspiration, but the results are pending. So first diagnosis is chronic gouty arthropathy. Second, osteoarthritis with calcium pyrophosphate deposition. Third is psoriatic arthropathy. Fourth is rheumatoid arthritis. Okay, good job, everybody. So osteoarthritis with CPPD was the favored option. A couple of people thinking rheumatoid or psoriatic arthropathy. But we can see the x-ray here really does show soft tissue calcification right above the ulna there. So that's something that if you're getting x-rays, you should just sort of think straight away of CPPD, because it does tend to happen in weird joints, non-weight bearing joints, and that is kind of pathognomonic for calcium pyrophosphate deposition disease. It can coexist with arthritis, that's often the case, but if you're just treating someone for arthritis, you're missing the other diagnosis, and you know, the crystal arthropathy from CPPD can need addressed specifically. It's more likely to benefit from colchicine, for instance, instead of just NSAIDs, I've found in my practice. So that was the right answer. And often the arthritis is in joints not typically affected by arthritis. And I think we've said as much as we need to about the rest of that. Next and final case, 72-year-old man here. And he is seen in the ER for severe pain and swelling, warmth in his right knee. It woke him up from sleep. There was no injury, but he was dancing down the street in the Highlands of Scotland, as you can see here. 3 months ago, he had a big swollen great toe. That got better within 3 days. And he didn't even need to seek treatment for it. He's on some medications for diabetes and hypertension. Those medications include hydrochlorothiazide, HTZ, and metformin. He's not quite febrile. He's not reached 100.4, but he's got an elevated temperature. His blood pressure's a little high, maybe because he's in pain. He's not got the best BMI in the world. And his right knee is warm and swollen, and it's tender to touch, decreased range of motion. Which is the most appropriate next step in management here? A, do we obtain a knee MRI? B, do we obtain a serum uric acid level? C, do we perform a joint aspiration? 4, do we empirically start colchicine? Or 5, do we empirically start indomethacin? Very good. So majority, 91% wanting to join or wanting to perform a joint aspirate. Some of these other things may be useful, but you really need to get an aspiration of this joint in this case. He's got an acutely swollen joint, which is warm, and I know he's got a history of gout, but before you do anything, you've got to exclude infection in this case. And hopefully that would be everyone's practice, to perform a joint aspiration, to send that for white cell count, to send that for gram staining culture, and sure, you're going to send it for crystals to confirm that it's, you know, negative birefringence. But first and foremost, before you empirically treat, you've got to exclude infection there, and that is the best practice. So he probably has gout. He's on hydrochlorothiazide, which we know increases your risk, and he's got the right demographics. He's got diabetes. He's a bit overweight. He's had a history of podagra, but you can't treat him until you rule out infection. And the other, you know, things, MRI, that's not going to help very much. Serum urate, it may assist in your diagnosis, but people can have gout even if they've got normal uric acid levels. And asymptomatic hyperuricemia is common too, so that doesn't really make the diagnosis. And sure, colchicine is a good option. That's my first line treatment, but you got to exclude infection first. So that brings us to my last slide here, just to thank everybody. That's my email if you want to email me questions. But if there are any questions from the presentation today, if you want to use the chat function, you should be able to do that. And happy to answer some questions. Let's see what the chat is saying. Kyle Arthur asked, do you suggest other treatment for CPPD other than colchicine? I've used NSAIDs. I've used steroid injections. Those are very reasonable, but I found some people respond better to colchicine. Remember, What colchicine does is different from NSAIDs. It actually affects the I think it's the macrophages in the joint space, and it inhibits their what they're doing. So it's got a different mechanism of action than NSAIDs in general, which we all know kind of more affect the cyclooxygenase and the prostaglandin synthesis. In the last case, would you start empiric antibiotics before aspirating? No. And that drives me nuts when they do that in the ER. They give them a blast of ceftriaxone before they get the fluid out the joint. If you really want to know what the organism is, don't empirically treat. You got to aspirate first. I think that's just good practice in general. What else do we have? Septic joint, do you still aspirate first? I mean, I'm going to say yes. I think for the same reasons I'd said before. Let's see, what else do we have here? What is your typical lab test for peripheral joint pain? Good question. If someone's got symmetrical joint pain, both limbs, I would start with rheumatoid factor, ANA, CRP sed rate. I would not jump to doing all the antibody tests that rheumatology does, because I'm probably going to miss something or request the wrong test, and that's expensive if you start getting, you know, crazy with you know, double-stranded DNA and smooth muscle antibody and all this and that. I mean, if you've got a specific diagnosis in mind, if you think that someone has you know, they've got bleeding from their nose and they've got lung disease and kidney disease, and you want to make sure that they don't have what we used to call Wegener's granulomatosis, I mean, you need an ANCA. That should be a specific test. But if it's just joint pain in general, I would just do some preliminary rheumatology labs without going nuts. How much information do you gather from the mucin clot? Not sure what that was in reference to. What is your approach to presumed polymyalgia rheumatica? Very good. I've seen this a few times. The thing with PMR is you usually make the diagnosis based on the sed rate, which is through the roof, and not just like 40, it's like 100. So I would get a sed rate. I would probably then empirically start prednisone. Patients, it's almost diagnostic. They have immediate benefit. Within 24 hours, they feel better. I remember a little old Italian woman that I treated with prednisone who had PM&R, and within a couple of days, she was bringing baked goods to the office and jumping about with glee. So it really helps overnight. So that's typically what I would do for polymyalgia rheumatica. They just need to be on corticosteroids, but typically at a low dose. Next question from Stephanie. What do you recommend for treatment of enthesitis in inflammatory arthritis? That's a good question, and I was actually hoping that I could have included a case today of spondyloarthropathy manifesting as enthesitis, because I think we miss that. We, you know, things like plantar fasciitis, if it's bilateral and recalcitrant to treatment, is often a peripheral enthesitis due to a spondyloarthropathy, and that's much more common in women, and it can be diagnosed with the same methodology, the HLA-B27, and in that case there may be different treatments. The thing with, I think the reason that the American College of Rheumatology has gotten more aggressive with diagnosis of spondyloarthropathies is there's better treatment now. They respond to the biologics, and in the past, you know, it was diagnosed late and people didn't necessarily respond as well. but now the biologics work, so make the diagnosis and get them in to see a rheumatologist. Okay, it probably is time to call it a day. Thank you for all your questions. That was great. Hope you enjoyed the more interactive platform today, and thank you.
Thank you, Dr. Kerr. That was a really great lecture, and I actually really thought the interactive aspect of it was awesome. I hope
Definitely
everyone got a lot out of it today.
Good. All right. Well, listen, everyone enjoy the rest of your week, and thank you very much.
Thank you. You too. Take care, everyone.
Bye.
And real quick before I get off, as people are logging off, next week's lecture will be on travel and sleep disorders on Thursday at 2:30 p.m. Eastern Time. And we'll have Dr. Nate Nye moderating and two of our colleagues helping to give that lecture together.